Hi guys, Dr. Gillard here once again. Hope everybody's doing well. Let's do week 3 of dermatology, shall we? Here we go. And we got some more work to do, some more new terms to learn. We're learning the language of dermatology. So let's talk about a nodule. Remember last week we had a macule and a papule. A macule was a flat mark on the skin that was not raised at all and was under 1 centimeter. A papule is a little bump on the skin that is less than 1 centimeter in size. So now we have a very similar, a round lump, but it's greater than 1 centimeter in size. And this is called a nodule. Note some other medical authors use 0.5 centimeters as the demarcation zone. But we will use greater than 1 because that's what the chiropractic dermatology book says to do. And other authors agree with that as well. The nodule is usually hard upon palpation. It could be a little soft, but it's got to be. I should probably take that soft out of there. As a matter of fact, let me make a note. Page 3. I should take that out because it's really just more of a hard nodule. But it's got to have some firmness to it. It's basically a hard nodule and it's round. Okay, it could be, what about a nodule versus a plaque? Because a plaque is also a raised lesion greater than centimeters. But remember, a plaque is like your plaque on the wall. It's got a flat top and it's not round. A nodule is also greater than 1 centimeter, but it's more roundish. It's more submerged into the skin as well. It's none away or deep-seated into the skin, where a plaque is more superficial, typically. This is a harder one, nodule versus a cyst. So both of these are round lesions greater than 1 centimeter. C for soft. I know it's not quite an S, but did I turn on my marker? Yeah, I think I did. Think of a cyst spelled like that for soft, right? Nodule is hard. One way to kind of memorize those things. And yep, both of them can have some depth. I mean, cysts are mostly submerged. Nodules are usually mostly submerged beneath the epidermis. But the cyst, unlike a nodule, will have a lot of fluid inside of it, a lot of gunk in there. Nodules are very firm and they don't have much fluid or gunk inside of them. Cysts, the key word is resilience. If you push into a cyst and let go quickly, it'll spring back. A nodule you can't even push into because it's so firm. So that's the difference between a cyst and a nodule. And here's like a little cartoon of a cyst. I mean, we can draw some, maybe a little bit of gunk, little fluid in here. Because there's wheals we have to talk about. I think we'll talk about those next week. But there's usually more, almost like if you ever seen a zit being squeezed and that stuff, the gunk that comes out of it, that's more of a cyst type thing. Oh, I guess we're differentiating a plaque here. So a nodule is usually more submerged. It's round. A plaque can be a little bit round, but in general it's way more flat and it doesn't go down like a nodule does. So if the nodule is really big, people often, or healthcare professionals and dermatologists, docs, tend to call them tumors. So a tumor is nothing more than a large nodule. I shouldn't say they never contain fluid. They might have a little bit of juice that you could squeeze out of them, but not, I mean, it's hard, it's solid, it's meaty, and same with a tumor. A cyst definitely has a more semi-fluid gel stuff that'll come out of it. The surface of a nodule could be smooth, it could be warty looking, verrucous is the word for that, or crater-like, and some stick up from the surface quite a bit. Some are actually really submerged, so it can be either. Usually they're more submerged, but I'll show you one. Here's one that's really stuck to the surface. There's not as much in the deep, but it still goes down into the epidermis and down into the dermis, but that's a nodule. But you never would ever call that a plaque. I mean, this thing is sticking way up above the skin. Right here's some pretty and swollen up lymph nodes here. Now, if you poke on these and they're super hard, they're classified as nodules. If they have some resilience and they're squishy, then you call them cysts. But regardless, this is lymph. Is this lymphadenitis or lymphadenopathy? Remember from CVPP. Well, it's starting to get a little red there, isn't it? This one's definitely lymphadenopathy. This might be getting lymphadenitis, starting to get a little discolored. Remember, when the skin discolored, that means the bacteria or bug or cancer, whatever's in there, is starting to spill up into the upper layers of the dermis and even into the epidermis. Nodules like papules result from, same thing, inflammatory processes, neoplastic growth, like a bacteria infection could do it. Cancer could do it. Metabolic deposits, uric acid crystals, people with gout is an example. Conition typically begins in the subcutaneous tissue and grows upward, so much deeper than papules or plaques. They're more superficial and might grow downward. Some good examples of nodules: a keloid, it's a scar tissue formation after some type of injury or some type of surgery. Rheumatoid nodules, we'll take a look at those. Basal cell carcinoma can often be nodular. Unlike melanoma, is usually more, it starts out as a macule and then can become raised into a plaque. Metastatic neoplasia. Let's see, lymphadenopathy, xanthoma could coalesce, all these little fat little cysts on top of the skin. I think we looked at yellow skin around the eyes. And they can coalesce into a larger plaque type thing, which is called a xanthoma or xanthelasma. I think we got slides on that when the time comes. Here's classic well, not classic, these are severe keloids. So when she was a little girl, she got her ear pierced. No big deal. Then she went to pierce her ears again, and she got herself keloid formation from skin cells growing wild in here. Okay, good example of a nodule, right? Those things will be rock hard. Rheumatoid nodules, you see this in your RA patients if you treat those people. Right? What side note for board thing? What's the other thing about rheumatoid arthritis that you have to worry about, chiropractors in particular? What about upper cervical adjustments? Better be really careful, right? It's an autoimmune type disease. It attacks the joints of the body, but who else does it attack? Transverse ligament of atlas, right? So that can be completely destroyed by an autoimmune attack, and there's no stability of atlas. If you adjust up there, they get in a car accident, that atlas can slip right forward and damage the spinal cord. So watch out for that. Basal cell carcinoma, nodule, nice, you can't tell, but it's hard. It's not like rock hard here, but it's harder than a cyst would be. And it's very dangerous looking, right? Look at the blood vessel growth. This thing is growing super fast. So that's a basal cell carcinoma. And now we have a wheal. So now we have another raised lesion that's greater than 1 centimeter in size. So it's elevated. It's usually flat-topped, so it's very similar to a plaque. But the difference is a plaque does not have fluid in it. In a wheal is filled with fluid. It's interstitial fluid. All right? So elevated, round or flat-top fluid-filled papule or plaque, you can think of it as, but it's not, because papules and plaques are not fluid-filled. So these are superficial. They don't go deep. They're not a cyst. They're not under the skin. You can't get your fingers. You'll pop it probably if you start squeezing it and trying to see if it has some depth to it. So how do you tell if it's a wheal or not? Wheals are classically have a little erythema to it. There's a fluid in there, but the key is how fast they go away. Just like evanescence here, Amy Lee of evanescence. Wheals are evanescent as well because they don't last more than a few hours. Some of them will go away within an hour or two. They might last a little bit longer, but usually not. They're very quick. If you had a bulla from a blister, which we'll talk about next week, a bulla can look just like that, right? If you get road rash or something, you fall, or you get that in the back of your heel, it looks the same. What's the difference between a bulla and a wheal? The wheal is evanescent, very short-lived, kind of like the group, right? They had that one great album. At least I lost track of them. They had that one really good album. They were short-lived. Wheals are short-lived as well. And unlike a cyst, won't go away, period, unless you get it cut out. If it's a blister, it'll take days to go away, right? Blisters are not typically itchy. These things are really, really itchy. They can be super itchy, so that's another difference. They're pruritic, or pruritic means itchy. If you get an outbreak of wheals, then you have a rash of wheals, and that's called a urticaria. If you want to add exanthem on there, that's our word for rash we learned last week. These can be characterized as a urticarial exanthem. Most lay people just call them hives. But if it's just one lesion, you don't call it a urticaria. If there's this thing, you don't call that, oh, he's got urticaria. No, he's got a wheal. Maybe it'll break into other wheals, then you could call it urticaria. But right now, he's just got a wheal. All right, and again, they last for a couple hours. Sometimes they can last longer, but they usually don't. Oh, wait, I shouldn't say that because it's the bulla. The blisters are really short-lived, a few hours. So these urticaria can last for hours, usually a day or so. My wife gets these, and they're usually around for 6 hours or so. Okay, so the wheals make up a urticarial exanthem. Okay, I'm not sure what happened there, but microphone off. I think my Dragon Natural speaking was the problem. Sorry about that. All right. We did the exanthem. There's some different looks for urticarial exanthem. They could also be, what are the causes of these things? Well, anaphylaxis, right? It could be an allergic reaction to something. In fact, it commonly is. Maybe you just ate shellfish for the first time and you're having a reaction. You're having anaphylaxis, and blood vessels are opening like crazy. Microcirculation is dilated, and you're flooding this area with fluid. It's almost like a mini patch of swelling here. Well, that's what it is. Could be an autoimmune disorder hitting something of the skin that it doesn't like anymore. Maybe cancer. The body can attack cancer in patches like that and make these urticarial pop up. My wife's friend died of breast cancer, and the first sign of it was she started getting hives. And they got tested, and it took about a year to figure out it was breast cancer. And they first removed the breast, and the hives went away until about 5 years later it came back, and that was a sad story. Anyway, so undiagnosed cancer out of the blue, if they start, you got to think stress. Some people, my wife, would get super stressed out. She could get these things. And then sometimes they just come out of the blue. No rhyme nor reason. Okay, that's enough vocabulary because that gets kind of tedious and boring. It's always good to get into the juicy diseases. So Lichen Simplex Chronicus, let's talk about LSC, not LSD. Pronounced Lichen Simplex Chronicus, like igloo, Chronicus, LSC. Pretty darn common. I think everybody's probably had a touch of this, or not everybody, but it's 12% of the population has had it. And it starts out as an itch. And we've all had an itch. And you scratch the itch. We've all scratched our itches. But most of us stop scratching the itch after maybe a day or less than a day. These people can't stop scratching the itch, and that is LSC, Lichen Simplex Chronicus, is a man-made condition. You get something that's itchy, and you can't stop scratching it. And I mean, you can try to stop scratching it, but maybe at night in your subconscious, you're scratching it. And you have to wear mittens at night. So it's perpetuated by scratching, right? Presents as it's an eczematous lesion. Did we talk about eczema? Yeah, eczema is pruritic, it's itchy, it's erythemic, it's excoriated. And it's just like a rash. There's classic eczema right there from scratching. So the lesion is caused and perpetuated by a patient rubbing or scratching. It results in a localized edema. It's not widespread like other eczematous conditions. So it's not all over like psoriasis or something like that. It's not all over the body. It's in one spot, and you keep scratching that darn spot. And it starts from some type of an itch or super dry skin sometimes, and you can't stop itching. The eczematous lesion is described as an eczematous lesion. All right, it's pruritic, it's erythemic, it's excoriated. It may start to get lichenified. This guy's been doing this for a while because it's starting to look like tree bark. Remember our word last week, lichenification. Excoriated, what does that mean? That's just like a rash or a scab. You get an erosion in your skin, or even an ulcer, and it gets down and blood serum starts oozing up. If it's an erosion that's not as deep as an ulcer is deep into the dermis, ulcer will leave a scar. Erosion will not typically leave a scar. But even erosion is going to start bubbling up a little bit of serum, tiny bleeding into it, and it forms a crust on it, and that's an excoriation. Sometimes it's called a scab, aka, or a crust. Is an or it's typically covered with a crust. So it doesn't have to always be covered with a crust. A crust is just a crusty thing on the top. It doesn't have to be covered. It just looks like that. I mean, there's not really much of a crust there, but there's cracks, and there's that's an excoriation. And there's a little crustiness. See the crust right here? A little crust starting to form. All right, let's see. Did that one? There's another one. It's getting a little flaky. It's getting a little bit of a crust starting, but that's an excoriation. There's some raw meat in there, and it's constantly being scratched. So this started as an insect bite and started scratching, couldn't stop scratching it. And 6 months later comes the dermatologist, and it's still there. I mean, we get an insect bite, that thing is gone, right, in a couple of days or at least a week. So they diagnosed with Lichen Simplex Chronicus. Wife said, "Oh yeah, he's moving and scratching in the bed, so got to wear socks and stop that. Put cortisone cream on there." Now, who's at risk for getting LSC? People with xerosis. Who's at risk? What is xerosis? That's nothing more than dry skin. Who's at risk for dry skin? Older people. They get dry skin really easy. People who have atopy. Do we know what atopy is? I think I talked about that in 5th quarter, but atopy means that you're allergic to everything. You have chronic sinusitis. You have allergies, all sorts of peanut allergies, shrimp allergies, spring fever, hay fever, fall fever, all allergic to those times of years. And then you have asthma on top of that. If you have those 3 things, you're atopic. So atopic people tend to develop this as well. People with psoriasis tend to get this. They get a bug bite on top of their psoriasis. Now they got a patch of LSC going on. They can't stop itching it. And stasis dermatitis, people with venous insufficiency. They have irritated skin. Some of the skin has died because of the high pressure down there. And it's always like semi-inflamed down there, and you get a bug bite down there, and it just gets itchy and swollen. Now there's some psychological conditions with this too. People who have anxiety tend to get more of this as like a nervous kind of a thing, because it feels good, right? When you scratch something, it feels really good, and so you keep scratching it. Obsessive compulsive people, they're more at risk for it. There's a neuropathic type of an itch where they actually have more C fiber that carries itch. And systemic diseases like amyloidosis is also increased risk for this condition. What is it caused by? Some believe it's caused by these people just have hypersensitive skin. Maybe they have, just like some people are hypersensitive to pain, these people are hypersensitive to itch because they have more fiber than other people do. It definitely has a psychological component to it. Everybody gets a little gratification. Some people get tremendous gratification out of scratching. I mean, some people cut themselves. They go beyond scratching, right? There's cutters who cut themselves. So yeah, it's kind of the same line of pathology there. You get an endorphin release when you scratch that itch. That's been proven. And it can become habit forming. Need your endorphins, so you're going to have to scratch, even though your lesion looks horrible. So you get a vicious cycle. Where's the favorite targets? Well, it has to be easy to itch, right? It's not going to be a place that, like right in the middle of your T9, you're not going to get it there because you can't itch there. So it's going to has to be amenable to being scratched. So the distal anterior lateral leg, you can actually itch that with your heel. People do that at night with their heel. The scrotum, the vulvula, the perineal region, classic spots for them to pop up there. Upper eyelids, your wrists and ankles, the backside of the neck, right where the hairline is. I've seen that many times. Or I'd say handful, not many times, but I've seen that on patients for sure. Thought it was psoriasis, and it turned out, no, just scratching a bug bite, and it keeps going on and on. So here's classic on one. The other ankle is fine. So, and has this been going on for a long time, or is this brand new? It's brand new. No, it's not brand new. How come it's not brand new? It's lichenified, right? It's got the tree bark look going on. That takes quite a while to develop. So he's probably been scratching this with the back of his heel because there's only faint excoriation here. If he's using his fingernails, he'll be all ripped up. But he's probably rubbing this with the heel, just enough to get his endorphin release. Here's a patient with chronic eczema around both eyes. So this might be okay if it's allergy season. I mean, it's not okay, but they put some cortisone cream on there. But this, again, they showed up in the dermatologist. It's been there for 6 months, way past the springtime allergy season. And then come to find out, husband says, rubbing her eyes all the time. Can't stop rubbing her eyes. So the rubbing is perpetuating the inflammation. Epidemiology, peak age is about 40 years, really uncommon in children. Women are more affected than men. Prevalence is big, right? 12% of the population. And yeah, we always talked about you get a vicious cycle of itch, inflammation. Makes it more itchy, and then you itch it. Makes it more inflammation, and then you itch it more, so you get in that vicious cycle. The itching, of course, releases histamine, what vasodilates the microcirculation, and it becomes swollen and red and more itchy, so you get in this cycle. Lichenification may start, and that indicates chronicity. It can go on for decades if the cycle's not broken. Some people become wired for itch, or maybe they're born like that with that wiring. It's kind of controversial. Can you grow more C fiber? You don't know, but they have tested people with LSC, and they do have more unmyelinated C fiber, which carries the sensation of itch as well as pain. One of the fibers, pain, be carried by several different types of fiber. But these people who have been tested, they have a decreased threshold for itch. They think about it and they get itchy just thinking about it. All right. So just like pain, some people can become wired for itch. Right. What about the natural history? It tends to be recurrent. You could battle it for 6 months and then it may just go away. And then it comes back again. You get by a bug, a flea bite or something, and it's the winter time. You turn on the heater, skin starts getting dry, and you just itch a little, and there you go. It starts it right off again. Early on, the skin is only somewhat affected. It's only somewhat lichenified. We said that. Later on, it can be permanently lichenified from this condition. Pretty much said that. There's his heel showing the doc how he scratches it at night, and his heel just has been rubbing this thing raw. Has this been going on for a long time? Yeah, it's lichenified. So it's been going on for quite a while. Scrotum, chronic scratching. That's not your heel, right? For sure. Those are pretty fresh excoriations. So that's he's scratching that thing pretty hard. And yep, LSC there, because we are equal opportunity, male and female class. There's the vulva. She's been scratching that as well, and has been going on for a long time. Sure has. It's all lichenified. She's not scratching it super hard, not enough to cause excoriation, but you can see it's gotten onto the thigh a little bit as well. And this is where I've seen it, right on the back of their head. You can also get eczema, or you can get psoriasis can show up right under the scalp as well. Treatment, well, you got to stop them from itching. I mean, this is a little baby. They don't get it very often, hardly ever. But if it's an adult, you have to do the same thing. You have to put gloves on, or you have to put socks on or shoes on so you don't do this subconsciously at night. Corticosteroids, you can try over the counters. Probably going to need something stronger from your primary doc. But corticosteroids can help. Even lidocaine, because, well, doc, that's for pain, right? Lidocaine's for pain. Well, it's the same fire, works on C fibers, so it's the same pain. Itch are carried down the same, so lidocaine works decent for this as well. Something called clobetasol also works very good to stopping the itch. And then watch out for infections. If you start getting a cellulitis, you need to take antibiotics for that. Right, should we go? Yeah, let's keep going. Dermatology, let's do some, let's keep going. Atopic dermatitis. So super common. Almost core, I think it's 24% of all children have a run-in with atopic dermatitis. And it's a little controversial how to classify this one. So you shouldn't call it eczema, although it does present. Remember, we said eczema is just the type of lesion that it forms. There's many conditions. LSC forms eczematous lesions. Atopic dermatitis forms eczematous lesions. Psoriasis can form eczematous lesions. So you should definitely not call it eczema, although some people do call it atopic eczema. As long as you have atopic in there, that's the key. So take a wild guess. What do you think this is associated with? Atopic, that's the hint. Had to be. These people are atopic. They tend to be allergic, have asthma and spring fever and allergic to peanuts and things like that. But not everybody, which is the kind of mystery of this thing. There's a lot of people who have atopic dermatitis and they don't have this stuff. It is recurrent, comes and goes, and when it comes, it's severely itchy. They say, none of our kids have had this, and I haven't had this, so can't give you firsthand experience on this one. But it's seen in a lot, almost a quarter of the population. And this, the patients, the eczematous lesions are much more widespread compared to Lichen LSC, Lichen Simplex Chronicus. Remember, that's just from itching. That's just in one place. This one will be very widespread. Kids all over the face. We'll see some pictures in a minute. It is considered a inflammatory condition, and most people believe it's autoimmune. So it's an autoimmune attack on some member of your skin, whether it be hemidesmosomes or desmosomes. There's a bunch of theories on that, but it appears to be autoimmune driven. But it is a confusing term, and they've been fighting over the term for a long time. Back in 1933, they used to call it eczema, but they realized other things cause eczema, so now they call it atopic dermatitis. Dermatitis is basically an AK for eczema, so that's where the atopic eczema comes from. But try to stay away from the word eczema. They used it as kind of a general category because there's many conditions that can cause this. Like there's an allergic eczema, non-allergic, true eczema. But yeah, anyway, that's not important. The important thing is the term stuck. So now we have atopic dermatitis, or at the worst, atopic eczema. So infants and toddlers, they get this on their face. It loves the face. It can get on the extensor surfaces as well. On adults, it's usually seen on the flexor surfaces, particularly the hands, and it's super itchy when it comes on. So here's a poor little guy. He's got it with nice blue eyes. But yeah, so there's no way that's LSC. Well, first of all, he's too young. But that's classic atopic dermatitis. There's another guy kind of healing. Got it really bad on his chest and face. Here's an adult. Loves the back of the hands on adults. Back of the legs, loves those too. Flexor surfaces, top of the hand, dorsum of the hand. Right down there, the dorsum of the feet as well. The prevalence has almost tripled. It's getting, whatever it is, it's getting worse. So that's why it's got to have some environmental component into it. And I mean, they still don't know 100% sure what the deal is. Some people just think it's an irritant contact dermatitis. We'll talk about the contact dermatitis. It's very similar to allergic, more similar to irritant contact dermatitis. Prevalence, again, is about 23% in children. Apologize, our neighbor's doing some woodwork out there with his garage door open again. So might hear some saw noises. I need some more foam in this room, I think. Anyway, prevalence 23% in children, 6% in adults. So that's a pretty big number for adults, though, right? To have this atopic dermatitis. 50% of the cases in children occur within 6 months of birth, and 85% begin within year 5. So it's definitely more of a childhood disease. About 70% of these kids do go into remission before adolescence, and a lot of them are permanently in remission. So not all of them go on to have adult atopic dermatitis. So comorbidities by age of 13. Well, guess what? This is where atopic came from. By the age 13, of the ones who got it when they're little, they developed atopy. And so they develop atopy. They have asthma. They have allergic rhinoconjunctivitis. That's the springtime allergies. I guess I should have told you that before. But that's where your mucous membranes are all flamed up. Right? And peanut allergies, I could have added that in there. And to this day, the pathogenicity is still not completely understood. It's autoimmune, though, most authors believe, and they think almost like Berger's disease, where cigarette smoke molecules, they go into the small arteries, like posterior tibial artery, peroneal artery, arteries of that size. They sink into the endothelium and they get into the nucleus of the endothelial cells, and they turn on genes that are not supposed to be on. And the body all of a sudden says, "Who are you? We don't know who you are," and attacks. So that's an autoimmune type disease generated by cigarette smoke. The same thing might be happening with environmental factors, where maybe there's something in the air that gets into the skin and turns on some genes, and now you've got a different look and your body doesn't like it and you attack. There's a barrier theory of the skin. Some of these people have barrier problems with their skin. So mutations, people with atopic dermatitis, they have mutations in the flagrin gene, tight junction gene, desmosome gene. So they don't stop. Remember, our skin has a barrier, and it has like a kind of waxy substance around that top layer of corneocytes, and it keeps stuff out. But these people don't have a very good barrier, and therefore allergens can leak in down into the dermis. I just described perfectly irritant contact dermatitis, or the other one, allergic contact dermatitis. So if this is true, these are really intermingled and maybe the same kind of combined into one. For your testing purposes, irritant contact dermatitis and allergic contact dermatitis will be different species. And the difference is that atopic dermatitis is autoimmune related, and these are not. But I'm just showing you that there is research that shows that the barrier is at fault. And if that's true, then it's probably not autoimmune, and it's more just like an irritant contact dermatitis. Okay, I know that's confusing. It'll make more sense once we start talking about these two. I think it's week 8. We talk about them. But there's questions about atopic dermatitis. Why does the eczema clear in some patients but not others? Could atopic dermatitis just be a glorified type of contact dermatitis? And a lot of people think so, including this author. So it's still a mystery, but it's super common in humans. Now, there are some associations with atopic dermatitis that don't appear to be with the contact dermatitises. So one is atopy. These people typically are atopic, and they have asthma, and they have spring fever and hay fever, and which is really called allergic rhinoconjunctivitis. They have food allergies. They have maybe eosinophilic esophagitis. Remember that, where we have stomach tissue growing in the esophagus? But not everybody is positive for it. So that's what's really kind of a mystery about this. One problem, the term atopy, is not all patients have they don't have atopy. They're not allergic to anything, yet they get an atopic dermatitis. So it doesn't fit neatly into that category. Treatment's just the same for any eczema. Emollient therapy, put some cream on there. If that doesn't work, cream usually works. That what is that stuff I use? It's like Cerbessa, I remember. CeraVe did I show you that? Yeah, it's a really good. Actually, we got dermatologists, Stanford dermatologists. That's I always used to see the little label on the bottle. Dermatologists recommended. I thought, oh, they all say that, but sure enough, that's Stanford recommended it. It's not greasy and it works good. CeraVe. If that doesn't work, then you need to get a steroid cream to come in. Watch for infection. If infection occurs, you'll have to get some type of antibiotic cream, or maybe even take real antibiotics, because you don't want to get septicemia if infection gets bad. You can take oral steroids like prednisone if it gets really, really bad and the rash is widespread. Okay, we made it. So I will see you guys on week 4. I don't know if it'll be in person yet. I have a feeling it won't be. I have a feeling we're going to be locked down this whole quarter. Just my guess. All right, see you next week. Email me questions if you have them.